is not always easy for me, but here we go. Good morning, all, and welcome to this Ask the Doctor Zoom discussion with Dr. Jeffrey Margolis. I'm Michelle, or Mickey McWilliams, and I work with Sid Moss at Cure Multiple Myeloma Corp. As always, before we begin, I'd like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Bristol Myers Squibb, Adaptive Biotechnologies, Amgen, Takeda, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to acknowledge Sid Moss, wave Sid, for those that are new here, the founder of Cure Multiple Myeloma Corporation. Sid and his organization are responsible for your breakfast snacks. Dr. Margolis is president of Michigan Healthcare Professionals PC and professor of oncology at Oakland University, William Beaumont School of Medicine. He specializes in treating multiple myeloma, and we are so pleased to have him here with us today. So the way this will work is Dr. Margolis will provide us with a little background on himself for those of you that don't know him. Then he'll give us an update on treatments and any other news as it relates to multiple myeloma. Then we'll open it up to questions from you. Please use the chat button to type in a question anytime during the discussion. I'll read all questions sent to me in advance and from the chat. Plus, we'll unmute and take questions from the floor. So again, thank you for taking the time for this Zoom session. Take it away, Dr. Margolis.
Thanks. Good morning, everyone. And I heard a lot of people are getting up in different time zones, so I really appreciate everyone getting up so early to talk about something that's dear to my heart, which is myeloma. As you probably know, I'm a practicing medical oncologist, and what that means is I'm a clinician. I see patients, and I have a passion for myeloma. So my job every day is to make this disease better. In addition, I'm a physician that runs a large medical. We have over 450 practicing physicians now in Michigan. So I have a pretty good idea of what's going on in the physician landscape, the payer landscape, and kind of the pressures that patients and physicians are undergoing during the pandemic, and what it costs to run practices, what it costs patients to get drugs, and kind of the economic burden that happens with myeloma as well. So I think I'm in a unique position to talk about that as well. But the most important thing is I'm a patient doctor. I see patients, and having conversations like this is something I do every day in my office. I enjoy doing this and look forward to talking to all of you about myeloma. So why don't we just open it up with questions and kind of figure out what direction we want to take things this morning. And
Okay, I have a couple questions. There's one in the chat right now, and we can start with the ones that are typed, because as people get going with all this, and at any time, just put a question in the chat if you don't want to blurt it out, and we will read them. Okay, so right now the first question in the chat is, about 1/3 of Karmanos multiple myeloma patients have no post-vax antibodies. Is there something in the works for them?
Yeah, so it's not just Karmanos patients that don't have antibodies. It's patients all over the country. And this is an important issue, especially in the midst of this pandemic. But one of the things that happens with myeloma is a disease of plasma cells. And those plasma cells make abnormal protein. And most of you have a protein spike that's being fouled, and that's that M protein. But one of the other things that happens in patients with myeloma is the myeloma cells prevent your immune system responding appropriately. And people with myeloma are predisposed to infection. And that's why many of the people on this call are taking some antibiotics or antiviral to prevent. We all know that because you don't respond as well to antibodies, you're more prone to getting infections. So that's why some people will also be getting immune globulin or pre-made antibody and something called IVIG. The last thing is that a lot of the medications that we're giving you to treat the myeloma also suppress the immune system. So it comes as no surprise that a significant number of people are not making antibodies to the COVID vaccine. Now, the first thing to remember is just because making an antibody doesn't mean that you haven't had an immune response. know exactly how to measure immune responses to the vaccine. We certainly would feel a whole lot better if you had an antibody and then we know you have a response. So there's a possibility that you antibody responses to make T-cell responses. Until we know that, though, the safest thing to do is if you have myeloma and you don't have an antibody response, you need to assume that you can respond to the antibody. You need to kind of go back to what we cheer to keep yourself healthy. And that is, again, continue with social distancing and continue with mask wearing. And there's going to be some caveats to that. The second thing is we need to get some education out there to people. And that there was an article that came out of Italy and it said, oh, patients with cancer respond fine to the vaccine. That's true for some cancer patients. If you have breast cancer, lung cancer, colon cancer, we have not found the same problem with the vaccine as we've had with myeloma, leukemia, lymphoma, and diseases that affect the blood cells. But I think that we want to make sure we that not all people respond to the vaccine. But what do we do? So what we've done in the past when doctors are controlling the vaccine is that often when people don't respond to a vaccine, we give them another vaccine. So, when people have been vaccinated for hepatitis, people have been for a shingles, or a variety of other things. Sometimes people who have compromised just need additional injections. Right now, we know it's absolutely safe for people to get additional injections. There's been studies with both Moderna and with Pfizer, as well as J&J, and people are looking at giving booster shots to the general population. There doesn't appear to be adverse events from it. Now, whether these additional injections will actually help and turn around and make it so people make antibody is still something we don't know. I think the real question is, how do you get another vaccine? Right now, the vaccine is still being distributed by the government, and they're at government vaccination sites. And even when they're given in the office, it's given through the government. And right now, the criteria to get a vaccine is if you've been vaccinated before. Every state is different. All the sites don't talk to each other. But when you register to get a vaccine, they do ask you that question. So you have to decide how you want to answer that question yourself. The other thing I think that's happening, though, is that the rest getting vaccinated is really important for all of you, because I think it really does change the landscape of who you can interact with and who you can be around. So if you have not had an antibody, but you want to be around people who have been vaccinated, I think the risk of transmission from someone that's vaccinated to someone that's unvaccinated is pretty darn small. And I think those people are pretty safe. The problem is that we haven't been very good about really separating out who's vaccinated, not vaccinated. And if you go into the grocery store and you look, no one's wearing, but I know state data that only a grocery store could possibly be vaccinated, yet they're not wearing masks. So I think that for people who have myeloma who've had but haven't had any responses, if you want to see people in your family who you know have been that have been vaccinated, I think that's more than okay. So I think small gatherings, in the house, being around people is important. I just think that public is going to put yourselves at risk right now. And I think the hardest one, are restaurants. It'd be nice to go back and sit out at the table outside. But if you don't have, you can't be for sure that the waiter who's waiting on you is vaccinated, nor are the people next to you, or if people come up next to you and talk to you at the table, that they've been vaccinated. So I think we still need to wait for the rest of the population to truly get vaccinated.
Right.
I hope that helps or doesn't disappoint too many people. Other questions about that?
Should I just read these down the list? Do you think, or how do you want to do it? Because they'll probably go
Is there a follow-up though? Any question about what I just said?
Let's see.
Because I'm sure that's on lots of people's minds.
I do have a question. So if you do have the antibodies, so vaccination happened, the antibodies level is 32, I think it was. Do we still need to wear masks when we go into the grocery store and go to church and such?
You know, most people who are vaccinated probably don't need to wear masks. The risk of infection is probably, very low. So if I had an antibody, I had myeloma, I would say after going into the grocery store, I'd probably still wear a mask and take extra precaution. But at the same time, if I wanted to go out for a restaurant or small family gathering or do something, I wouldn't have a problem going ahead and doing that. So, it doesn't hurt to wear a mask during some periods of time, but but I wouldn't restrict myself from, doing things because you probably do have a good response to the vaccine. And 32 is not an unreasonable response to the vaccine.
Anyone else have a question regarding COVID and the and multiple myeloma patients? Okay, here's one. COVID-19 variants become like flu. Will COVID come back every year? We do have first shot COVID-19 vaccine on April 4th, and we'll have another shot on the 27th this month, when we will have antibodies to COVID-19 from our bodies. So I guess I guess this is a question about how long the antibodies last. And
so any virus or anything, whether it's cancer or infection, is evolution in process. So the more the virus has a chance to replicate, there are small little DNA mistakes that happen in the virus. Those little DNA mistakes either give the virus an advantage to be more contagious, less infectious, more deadly. And over time, you get selection of these viruses, and that's what a variant is. And so the more people that are getting active infections, the more infections that are going on, the more variant that it breeds. So the goal to wipe out COVID so it never happens again is you need to wipe the map and not let it divide. And that's why it's important that we get everyone in the United States vaccinated, but you also need to get people in the rest of the world vaccinated, because we don't live in, and people travel, they move, and you can see how something's part of the world and ends up in this part of the world. So the emergence of variants is affecting what else happens in the world. So if you see the newest variant that's come in is a variant that's coming in from India, and that's because COVID's been running rampant, in India. The good news is that the variants that seem to be happening happen to the spike protein. And the beautiful thing is that the people at Moderna and at Pfizer, their vaccine technology is basically a vehicle for the vaccine. And all they have to do to change the variant is change what passenger they put in the vaccine. So all the hard work of how to make the vaccine work, how to make the vaccine, how to deliver it, how to get it safe is all done. So if a big variant starts to arrive, they would just change the spike protein that they put into the delivery device, and then we could start to revaccinate people. So I do think at some time you're probably going to get a booster vaccine, and we can keep people safe. I think there's a chance that you're going to wipe COVID off and there's never going to be COVID again, but it's going to take big cooperation of the entire world before that happens. Otherwise, we're going to be dealing with this for a while. Good news is that we've got a lot more tools going into than most people, I think, really recognize. So we've now have got preventive tools, and that tool is a vaccine. We also know that if you are on top of this and you recognize when someone has COVID and you have the correct testing and you isolate them, you can prevent this from spreading to the community. And a good example of that is tuberculosis. The world has never, tuberculosis, and in some parts of the world, tuberculosis is still, rampant. You see very, very little tuberculosis here in the United States. And that's because as soon as someone tests positive for TB, the health department is on it. They find the person that has tuberculosis, they quarantine that person. They do really good contact tracing. They find everyone else that person's been in contact with. They isolate them, and they don't give the disease a chance to spread. Well, once the disease is under control, which is starting to become now, we can institute those kinds of health policies, which we've had here for a long time. And then the third thing that really kind of was the unsung hero in COVID, which I think is really, really important, especially on this call, is that there are pre-made antibodies that that two companies make, Regeneron and Eli Lilly, are antibodies to the COVID. So they're preformed antibodies that they grow in a lab that can neutralize COVID. And if you COVID and you test positive before you get really sick, if you get to the doctor, you can get infusions of these pre-made antibodies. That's exactly what President Trump got sick. He got the Regeneron antibody before it was FDA approved. It's now FDA approved. The Lilly antibody is, now FDA approved and commercially available. And what we've seen is many of the patients who get that pre-made antibody, within 24 to 48 hours, their fever, they get, all symptoms go away and they get better very quickly. The key is you have to be treated early. Once you're really sick and the immune system gets unregulated, people don't respond very well to this antibody and you can't use it. For the people who get really sick, who get past that window, then there are medicines like steroids and remdesivir that can be used well. And those work okay. But the key is really getting on this quick so you can get these monoclonal antibodies that really do work quite well.
Couple other things here that are related to this. One question was grandchildren. Which is it all right to, some of these kids certainly aren't vaccinated yet. What do you do about seeing your grandchildren?
Yeah, that's my least favorite question. And I get it. I know everyone wants to see their grandchildren. And the problem right now is that the kids are potentially vectors or the ability to spread the virus. If the kids are vaccinated, we, have seen them. If the kids are not vaccinated, then I think we need to continue, and you don't have antibodies, then I think you need to continue with the Zoom calls. I think you can do visits with the grandkids, outside, preferably both sides wearing masks, I think are fine. But I think you have to be careful resuming activities more.
And one more question on this same topic. Is there a limited window of time after vaccination when you can determine whether or not there has been an antibody response?
Yeah, so that's a great question. So we don't know yet what responses are. What we do know is that when you vaccinate people, usually 2 to 4 weeks after your last vaccine, that's when your antibody level is going to be at its peak. It's going to be at its highest. And then over time, the body, and what we find is that antibody level will sustain itself for long periods of time. So depending on when you check it, your antibody level may be or lower. And that's why we try not to use an absolute number of antibody to say, okay, you're immune or you're not immune. I've seen people who have antibody levels of 1,000, and then 2 months, later, it dropped down to 10 or 12. I've seen people who've had antibody responses and they're 30, and 2 months later, they're 12. So I think as long as you have some circulating antibody that you're probably immune. We know that we follow regular people out who aren't on immunosuppressive drugs. And, the antibody is lasting well over 6 months, probably good for at least a year.
Okay, one more on this, and you've kind of touched on this, but have you, answering the question, have you been vaccinated? Should a patient try to get a booster or different vaccine? You know, if one doesn't work, should they try a different one?
So it was the question, have I been vaccinated? Yes. So if the vaccine was in your office and the doctors were prescribing the vaccines, then I think the answer is yeah. I think most oncologists would, if it was in the office, I'd pull it out of the back, I would give you another vaccine. There are some very interesting strategies in looking at whether you should mix and match the vaccines. The idea is that if you were to mix and match the vaccines, then maybe you'd make a few different kinds of antibodies against COVID, and maybe that would be better. The other strategy is, if you, with the same vaccine, maybe the antibody response that you already had would become stronger. We know for sure that out of happenstance, there were people that forgot that they got Pfizer and then went and got Moderna, or people that got a Moderna and got a Pfizer. People got a J&J, then didn't realize get a second vaccine. Got a Moderna or a Pfizer. It's happened, and what we situation is that it's safe. Nothing bad happens. There is some data to suggest if you mix in the vaccines that you might get more side effects. If you have a good antibody response and you give a third vaccine, then when you give that vaccine, your antibodies may just destroy the vaccine right away. You don't need it. You don't get much of an antibody response. The fact that you're getting some antibody response that may be stronger, and may mean that your body is making more of an immune response, to the vaccine. So in that situation, I think we don't know what the right answer is. I think that you could do any of the above. None of them are going to do anything bad to you, but to tell you which one would be the best strategy, I don't think anyone, knows right now. The issue really is the mechanics of how do you get another vaccine or how do you get a booster. Right now, for people who had a response vaccine, the CDC not made a statement on what to do, which means there is no health policy in place for who haven't had a response to get the third vaccine. So right now, all the vaccines are being given, and the vaccine instructions places are all being the same, which is you ask a question, have you been vaccinated? You say no, and then they go ahead and they give you a free vaccine. If you answer yes on that question, they're going to tell you that you don't qualify for come back again. So you have to do what you feel is the right thing in your heart. What I tell you is that it's definitely safe to get another vaccine.
Maybe what I should do is move on to some of the other questions. There's a bunch of them in the chat now.
I guess have I had patients who have gotten extra vaccines? The answer is yes.
Has it worked?
I don't know yet. So we're in the process of letting that go, and then get new titers to see what happens.
Yep, it's interesting. Well, hopefully we'll be able to find out pretty soon, and maybe we can convene again when you know some more things about how some of these patients are doing.
Absolutely.
Okay, good. Okay, so I'll just kind of move on here. One of them I got prior to this. It was a question about, I'd still like to know if there is a clinical trial that people who have had CAR T and are going out of remission qualify for, or if there now is an approved treatment after CAR T.
So I guess the question is there a trial for people who have relapsed after CAR T? I'm sure there are trials that are available. The trials change on a basis. The Myeloma Foundation, good place to look. The NIH has a site that we often will put people through to look and see what they qualify for. When you look for clinical trials, the clinical trials have very strict guidelines of who can get treatment and who can't. So it depends often on how many treatments that you've had. It depends on what kind of treatments you've had. Sometimes it depends on the last time you have been treated. The guidelines for putting people on the trials also changed. So you might imagine before CAR T was commercially available or before CAR T existed, no one had any of those things listed in the trials. All the trials are constantly updated to do things. Off of a clinical trial, though, there is no reason that any of the drugs that are available for myeloma can't be mixed and matched and put into people with CAR T. So once you've had CAR T, and if you've had CAR T and it's failed, that doesn't has to be the end of the line. It doesn't mean there's not any treatment. What we would then do is we would look at what treatments you've had, what treatments you responded to, when was the last time you had some of those treatments, and you can certainly reintroduce those treatments.
Okay, here's one that's going to be hard for me. What is the difference between autologous, Logous BMT and allogenic BMT?
So an autologous stem cell transplant is a transplant that you're using your own stem cells. So the reason that autologous transplants work is there's something called a dose response curve to chemo. And the idea is that for multiple myeloma, the reason that you can't kill enough of the myeloma is you can't give enough chemotherapy. But if you could give a chemotherapy, you could wipe out a lot more of the myeloma cells. The problem is that as you give higher and higher doses of chemotherapy, it wipes out your body's stem cells. So melphalan was one of the first drugs that was used for myeloma. And melphalan had a dose response curve. The more you gave, the more myeloma you killed. Problem was, as you started to give huge doses of melphalan, you would wipe out a person's counts, meaning that they would no longer be able to make blood. So their whole immune system would be wiped out. They would no longer make white blood cells. They would no longer make red blood cells. They would no longer make platelets. So that was the dose toxicity of melphalan. Give more than that. So people got the idea that if you took someone's stem cells and you took them out of their body and you put them in a freezer, you could give high doses of melphalan, essentially lethal doses of melphalan, kill off tons of myeloma, and then give the stem cells back to the person to rescue them from the toxicity of the high dose of chemotherapy. And that's what an autologous stem cell transplant. It's just a trick to be able to give high doses of medication and then rescue the person from the toxicity. An allogeneic transplant is a little bit different. In an allogeneic transplant, you use someone else's stem cells to rescue people from the high dose of chemotherapy and prevent the toxicity. And when this originally was done, people thought, well, the reason that's probably a better form of transplant is that when you rescue people with their own stem cells, you probably take out their stem cells. But coming from someone that's got myeloma, you're probably also infusing back myeloma cells. So it wasn't a pure form of stem cell transplant. In an allogeneic transplant, since you're using stem cells from another person, there's going to be no contamination with myeloma, so it should be better. And it turns out that the infusing back the myeloma cells and the clean part doesn't make very much of a difference. But what happened with allogeneic transplants is, besides rescuing people with high side effects of the chemotherapy, it turns out that the allogeneic transplant itself has a very, very, very potent immune response to the myeloma. And that stem cell transplant, the new immune system that came from someone else, gets put into your body. And as those cells start to grow up, they actually know how to kill the myeloma cells. And they can actually kill it. And that's called graft versus myeloma effect. So there were a lot of reasons to have a lot of hope for allogeneic stem cell transplants in myeloma. The problem is that allogeneic stem cell transplants were very dangerous. And because the stem cells come from somebody else, There were limited donors. And more importantly, when the stem cells went in, besides getting this graft versus myeloma effect, you also got something called graft versus host disease, where the new stem cells that came in recognized the body they went into was foreign and basically rejected the body. People got very sick. And so what happened with myeloma is that many people got these transplants, and a large number of them died from the effects of the stem cell transplant. So we know that people who have myeloma compared to other diseases tend to have more complications with allogeneic transplant. And we also know that allogeneic transplant complications go up significantly with age. And so most people with myeloma are of older age, so it limits the number of people who can get it. So if there is someone who has, multiple myeloma, who is, very young, in their 40s, sometimes, certainly under 50, we'll still consider allogeneic transplants for it. I've done occasional allogeneic transplants for people who have twins as a way to do it, and in very, limited circumstances. But most of the allogeneic transplants kind of fallen by the wayside just because of the extreme increase in toxicity.
Different topic here, but it's been mentioned that myeloma patients with bone involvement shouldn't do overhead weightlifting to protect against compression factors. So how does one maintain bone density and strength to ward off encroaching osteoporosis?
Okay. So one of the things that happens with patients with myeloma is you get those lytic bone lesions, spine, in your femurs, and any bone in your body. So left unchecked, people with myeloma have problems with their bones and they can get pathologic fractures. Fortunately, we are doing a lot of things in all of you to prevent that from happening. Most of you are either hyaluronic acid every month or every 3 months. You're getting Xgeva once a month. So those medicines reduce the risk of skeletal complications by making your bones more resistant to the myeloma. But I'm going to tell you a little secret. If you look at Xgeva, it's just Prolia, which is the drug that you use to treat osteoporosis, at a higher dose given more often. So Prolia is given at 60 milligrams twice a year. Xgeva is the same drug given at 120 milligrams once a month. Zometa, or zoledronic acid, is the same medicine as Reclast, which is the medicine we use to treat osteoporosis, except Reclast is given once a year. So all of you are already getting medicines to fight osteoporosis every single day. As far as exercise goes, that's something that I think evolves. When you're first diagnosed with myeloma and we don't have the disease under control and you've got lots of bone lesions and we're working on getting things treated, I think that being careful with the kind of weights and the kind of exercises that you do. But there are lots of you, and some of you are my patients out there. You're in remission, you're already doing well, you haven't had skeletal complications, in years. We've looked with scans and we look with things. You're probably more than safe to do, exercises and weights and things like that. So I think that just like everything else, we need to individualize this. And I think where you are in your disease, where the location of these bone lesions are, a discussion with your doctor about getting yourself, back to exercising. But I think most people with myeloma at some time in their disease are going to get back to being able to do normal amounts of exercise.
I've heard other myeloma clinicians say that they are starting to assess MRD in their practice. Is this a test you perform on your patients?
So MRD is certainly something that you can do. The problem is no one knows what to do with it. And so you get a test back and then you're left with, well, what do you do with it? So if someone wants to get MRD done, I'm certainly willing to do it. But for the most part, I don't think it's very helpful yet outside of a clinical trial, because you're going to get a result and now you're going to say, what should we do with it? And in the past, when people started doing things to treat MRD, by trying to re-intensify therapy, it actually made things worse. So I think it's an important research tool. It's an important thing to do in a clinical trial. It may be a surrogate for finding endpoints quicker in clinical trials. The idea is that if you're comparing two trials and you're comparing treatment A versus treatment B, and one gets more MRD, then you may not have to wait as long to find out if that trial actually has a survival advantage. The assumption is if you get more MRD, you'll actually do better, and then you don't have to wait as long to get the trial results. But for routine clinical use, MRD is probably not that helpful.
Okay, here's another hard one. Hard for me because I have to pronounce it. Is it different? What's the difference between extramedullary plasmatoma and multiple myeloma? And do you treat these the same?
Yeah. So there are a family of plasma cells disorders, and an extramedullary plasmacytoma or an isolated plasmacytoma and multiple myeloma are in the spectrum of diseases. So when people have myeloma, the different lesions in your bone are basically plasma cell tumors. The reason it's called multiple myeloma is that you have multiple tumors. There are occasionally people that will present to the office who have one spot that has got myeloma cells in it, plasma cells. That's called a plasmacytoma. And people who have plasmacytoma, two groups of people who have plasmacytomas. One group has got it in soft tissues. So you can get them in the lung, you can get them in the sinuses, or you can get them in the bone. If you look at people who have isolated plasmacytomas, we look for myeloma. So we do PET scans, we do MRIs, we do bone marrows. You can't find anything, and now you're left with just one place. Typically, the treatment for that is to do radiation treatment. And for some patients, radiation treatment is curative because it truly is an isolated disease just in that one place. What we know is if it's a soft tissue plasmacytoma, 2/3 of those patients are cured with radiation. If it's a bone plasmacytoma, most of those patients really do have multiple myeloma. We treat them with radiation to that one site, and then typically over the next couple of years, they do develop myeloma, and that usually happens about 2/3 of the time. So we absolutely treat them differently, but they're on the spectrum of the same disease.
Okay, here's another COVID question, but this is something I think that people are going to, it says, assuming I have both vaccinations for COVID-19 and have antibodies, is it inadvisable to attend a wedding in August with 100 people where my guests will be unmasked? Where many guests will be unmasked?
So I think that, that it is safe when you are vaccinated and have antibodies to resume, normal activities. The key is that what really should happen is the people who are vaccinated should are more than welcome to take their masks off. The people who are unvaccinated really should not. And so the hard part about having weddings and gatherings and doing things is what to do with the people who aren't vaccinated. And that's really been, I think, a question of conscience of what the people who are vaccinated and unvaccinated are doing. I wish the people who were unvaccinated, if that's the choice that they make, would say that that choice also requires them to wear a mask. And then these questions wouldn't be very difficult to answer because then everyone can kind of mix. You just realize that the bigger the gathering is, the more likely you're going to come into contact with people who are unvaccinated. The vaccines are not perfect. The vaccines prevent 95% of people from getting COVID. So if they're unvaccinated people that are there, they certainly can still be carrying COVID, and you can certainly get a risk of getting COVID, though it's a small risk. So you have to, weigh what risk that you're willing to take. Every day when you get in your car, you take a risk that something may happen. You do things to mitigate that risk. You drive the speed limit, you follow the traffic signals, you put on your seatbelt, and you take some risk. So you have to decide how important that wedding is, how many people are going to be vaccinated, unvaccinated there. And then I think you can make an educated, guess. But I think for the most events and most things, I think you can, start to resume a lot of, normal activities. I really wonder what's going to happen when you fill, a stadium full of not 100 people, but 20,000 people to watch, a basketball game or, to watch a hockey game, how well that's really going to go. But I think that's to be seen.
Have you had multiple myeloma patients who have needed and handled heart surgery well?
Yes. So again, myeloma is really no longer an acute disease. It's a chronic disease. And because we're doing so well with myeloma, many of you have been around for years and years and years. And as you go into remission and you continue to do well, you're not immune from regular health, problems. And so people who have myeloma start to require heart surgery. They require, appendix surgery. Some people want cosmetic surgery, and what I usually tell people is, and I tell the doctors who take care of people with myeloma, if your myeloma is in remission, start treating people normal. Don't make the myeloma the rate limiting, step. So if you need heart surgery because you've got, bad coronary disease, you've got a bad valve or something that's going on, that's going to be the thing that's immediately, life threatening right now. And that's the thing that needs to be dealt with. So there are things that we do to try to get people ready, for big surgery. So sometimes it's stopping some of your medications, a couple weeks before the surgery, holding them, after the surgery. If you've been on steroids for long periods of time, you can have something called adrenal insufficiency, and you might need some steroids during the surgery. But we can certainly get people through most of these surgeries. It just needs to make sure that the surgeons are in contact with your oncologist.
Here's one I received earlier. What is immunotherapy in treatment of cancer?
So when we started treating people with cancer, most of the treatment was using cytotoxic chemotherapy. And those are drugs that are used to target the cancer directly and damage. But for the longest time, people recognized that the immune system plays an important role in cancer. So one of the things that happened very early on in the treatment of cancer is that people made pre-made antibodies. So we've been talking a lot about that COVID vaccine. The idea of the COVID vaccine was for you to make antibodies against COVID. Well, you can't make antibodies against cancer very effectively, but the people who sponsored these calls do. And so in lymphoma, there was an anti-CD20 monoclonal antibody, and that anti-CD20 monoclonal antibody is called Rituxan. And that is your immune system, but it's pre-made, and we infuse that into your body. Those antibodies target the lymphoma and they kill the lymphoma. That helps bring your immune system to the lymphoma and it kills it. Fortunately for myeloma, there are two immune therapies that are there, right now. There's anti-CD138 treatment in medicines like Darzalex, and then there are monoclonal antibodies to BCMA, and those are again pre-made antibodies to targets that are on the myeloma cells. We also try to do immune therapy in lots of places in cancer with something called PD-L1 inhibitors. And for the longest time in oncology, people were trying vaccines, they were trying things to enhance the immune system. And the truth is, it didn't work very well. And people kept scratching their heads and saying, well, how come this isn't working very well? I'm giving people, vaccines and I'm making things and people still aren't responding. Well, part of the issue is that when you have immune therapy, your body has an accelerator and it has a brake. And one of the things that the immune system has is like an emergency brake. And that emergency room brake is something called PD-L1. And PD-L1 is something that your immune system uses to check itself, to turn itself off, and to say, hey, better not attack this. So the newest thing in oncology is that we have PD-L1 inhibitors. And these are drugs that turn the brakes off the immune system and allow the immune system to attack the cancer. We have done that. We have seen beyond miracles with cancer. The first group of patients that got treated with these PD-L1 inhibitors were people with melanoma. They were treated almost 10 years ago. It was a horrible disease. Chemotherapy didn't work. Nothing worked. 10 years later, I'm proud to say that 23% of those patients are alive with no cancer. We are now using PD-L1 inhibitors for every known cancer. There's every known kind of trial doing it. And the truth is, for a small study, remission, people, are in remission 2-3 years after their diagnosis with no cancer, kidney cancer, Hodgkin's disease, you name it, it's happening. And we're doing treatments with those kinds of drugs in myeloma to try to get the immune system, on. The other thing that it opens up the door is it may be that it's time to bring back some of the vaccine trials and some of the things we used in the past, because the reason those weren't working is because the brakes were on. So you may be able to reintroduce some of those treatments, but now use something to turn the brakes off and put those treatments in. And then the last type of immune therapy is CAR T cell therapy. And what CAR T cell therapy does is it says, hey, listen, a normal person's immune system isn't able to kill myeloma. So what I'm going to do is I'm going to make super soldiers. And they actually take your immune system out of your body. It goes to the company that's doing the T cells. It genetically engineers these T cells to make these T cells super myeloma killers. So they're engineered to do one thing. It's like going to Navy SEAL school. They make these Navy SEALs to kill myeloma, and then they infuse them back into your body. And what's amazing about this is that then these T cells go to work killing the myeloma. But because they're your immune system, they actually grow, and you actually make more of them. So you originally get infused, let's say 1,000 of these T cells, a couple of weeks later, you got 2,000 of them. And then a couple of weeks later, you got 4,000 of them. So you basically get your own army against myeloma. And so we're now seeing very cool responses with CAR T. This is just the beginning, because right now we've engineered Navy SEALs, but maybe in the next 6 months or a year, we'll introduce some Navy SEALs. Maybe we'll have some, Marines and some Army, and we'll have 3 or 4 or 5 different kinds of genetically engineered T cells that we can put into you and finally wipe this thing out forever. So I think we're really, really excited about CAR T cell therapy, because now we can actually get the immune system to be trained and work how we want it to work. All right, other questions?
Okay, so here's another question along the same line, I think, and I'm not sure if this is it BITE or BITE specific immunotherapy similar to CAR T cell therapy? Will that replace CAR T cell therapy? It's much more affordable.
So it's another way of training the immune system to work, and it's using a bridging antibody to put two things together and make the immune system work. And I think there's a lot of excitement about doing BITE cell therapy. We've got BITE cell trials that are open. And I think when you look at all these things, they're all tools in the ability to treat, myeloma. And like everything else in myeloma, when we treat you, no one gets one drug. Everyone gets combinations of treatment. And so each time you introduce a new treatment into our armamentarium for taking care of myeloma, it then means then you can use other combinations. So it might be that you use CAR T cells, thus you add BITE therapy, to it. You may add CAR T cells with, protease inhibitors. It may be with immune modulators. And I think you're going to start to see more and more things happen. And the more tools that you get, every time you add one drug, It doesn't add one therapy, it adds 10 or 15 therapies because that drug can be added to other things in combination. And it's really that combination of things that have made the huge progress in myeloma. And that's going to be what eventually cures myeloma, by putting all these things, together.
Okay, another question. If they are able to avoid infection, is a long-term multiple myeloma patient more likely to die of a different medical condition than the disease of multiple myeloma?
So the longer you live, the more likely you're going to die of something, else. Everyone has to eventually pass away. Our hope is that eventually people with myeloma are living normal lives, and they're getting the same rates of heart disease or stroke or lung disease that everybody else is. Unfortunately, right now, still with myeloma, the biggest threat to people's health with myeloma is still myeloma. But we're starting to see that change. When we look at myeloma, we do see some toxicities that we cause with our treatment. And that's the things that try to give us, pause. So the immune suppressive problems that we cause with myeloma and from the disease. So people with myeloma are at increased risk of having infectious complications. The other thing that we sometimes will see in patients with myeloma is they get second malignancies, and they're at higher risk for getting some hematologic malignancies. And then we also will see something called myelodysplasia. And myelodysplasia is a disorder of the bone marrow, and it's probably caused by some of the treatments that we give for myeloma. And the biggest culprit of causing myelodysplasia would be stem cell transplants. And the alkylating agents that we give in the stem cell transplants can potentially damage the stem cells. And when those stem cells get damaged, it can generate a pre-leukemia state called myelodysplasia.
What is the average and longest duration of response to CAR T cell therapy?
It's very variable. There are some patients that are still out there with CAR T that have been in remission for years. Some of them, are in remission for 9 or 10 months. Part of the problem when you start to ask those questions are, who are you treating? So remember, the only people who were eligible to get CAR T cell treatment in the past were people who had horrible myeloma. You had to failed everything. So you're already taking people who are predisposed to, not doing well with treatment, and then you gave them CAR T. So I think that really to know how well CAR T is going to do is when you start to use CAR T cell early in treatment when people have sensitive disease. As we talked earlier about the COVID, over time, the COVID evolves and it changes, it gets mutations. Well, the same thing happens in myeloma. So the more resistant the disease gets, the more the disease evolves, the harder it is to kill. So early myeloma has a lot more sensitive cells to it. It's easier to treat. It's easier to control. Refractory myeloma is more resistant to treatment, harder to control, and people don't do as well. So when you're trying to evaluate treatments, it's really important that when you look at the treatments, you look at what line of therapy people got the treatment. So if something had a 30% response rate in fifth line treatment, it doesn't mean it's really not a good drug. It just means in fifth line treatment, it's not so good. It could have a 90% response rate in first line treatment. So right now is a treatment that we're only using at the end of treatment, not at the beginning. And I think what we really want to do is start to move that up in treatment.
So I have a couple of comments here that I think are important to read to you. Dr. Margolis, thank you so much for presenting such detailed, complicated information in such a clear manner. You are exceptional and it is so appreciated. And then
Thank you.
another one, and the second one, well said. I agree with Judy. Dr. Margolis, you and your practice are exceptional. So
Thank you.
And it is difficult. All this information is really hard to understand to the layperson like me. So it is good to have someone that can explain this in terms that we can all kind of grasp, and that is well appreciated. So anyone else? I think we've gone through the questions here. Does anyone else have a question? We only have like a few more minutes. So are there any questions? You can type them in or unmute and just ask your questions.
Dr. Margolis, what locations do you see myeloma patients at?
So we have offices all over the city, but I personally could only be at 2 of them. So I'm at the Royal Oak Cancer Center and at Beaumont and 13 in Woodward. And then I have a office on Northwestern Highway.
Any other questions?
Thank you.
So Dr. Margolis, I do have a question that was asked for patients that don't live near, that don't live in the metropolitan Detroit area and have multiple myeloma. How do they find a qualified physician to see, a qualified oncologist?
That's a great question. So I'm an old-fashioned doctor, and I still believe the way that you find a doctor is you ask other doctors. The doctors know who the right doctors are, or you ask patients, and they're great sources of doing it. I try not to refer to institutions because where I practice, they're great doctors, and there's some doctors are okay. And that's the same thing anywhere, in the country. I'm also not a big fan of, doing, Google searches and trying to, find someone. The best thing to do is to talk to other people that have seen that physician and find out what they think, see how people are doing, or ask other doctors in the area because they're interacting with those people on a day-to-day basis.
Thanks. All right, here's one more question that's pretty specific. My spouse has carried multiple myeloma on pancreas after RVD cocktail chemotherapy and acupuncture and traditional herb medicine 2 years and Velcade maintenance chemotherapy over 5 years since 2011, and collected and saved her own stem cells for BMT in 2012 if needed. When is the best time to have a bone marrow transplant?
So that's a great question. So we typically will treat people in their first remission for stem cell transplants. And the reason that people choose that is because that's when the disease is the least resistant, and a lot of logistical reasons. So one, most centers will not continue to store stem cells for years and years. And so once you have the stem cells, you got to use them, or eventually they throw them away, or you got to find someone to store them, and you have to pay a storage fee. The second thing that happens in patients with myeloma is that people are older. So if you wait longer and longer and longer to do the stem cell transplant, you get older and older, and then you potentially age yourself out of getting the transplant. In addition, when we look at myeloma, not everyone lives in an area when they can get a stem cell transplant and has the resources to get it. And what we know is that of the patients who are eligible to get stem cell transplants, only about 50% of the patients actually get the transplants. So a lot of people don't get the transplants. And one of the concerns is that sometimes what happens is people wait and then they go into, a crisis. They can't get back into remission. They never make it to do it. So it's one of those things that our preference is to transplant people immediately. There is no true proof that you can't use the rainy day theory, which is use the treatment that you have now and you run it as long as you can. And then when your day comes that it doesn't work, use that as your salvage treatment. And that's a very reasonable, strategy. There's just sometimes some logistical, hiccups with doing it. The other thing is, if you look at stem cell transplant as a modality, the efficacy and the superiority of stem cell transplant over conventional treatment was only when we didn't have a lot of really good treatment for myeloma. So using a lot of these modern treatments and things that we have, it's harder to know how important stem cell transplant is. And what we've always thought is if you've got good treatment and good treatment, 2 good treatments have to equal best treatment. And there's probably some truth to that. But at the same time, at the time, there wasn't very much treatment. Now there's lots of treatment. So I can't tell you that, you even have to have a stem cell transplant because we've got so many other treatments. And a lot of the medical treatments that we have. So if you look at RVD, which most of you have gotten, and you compare that to old stem cell transplant data, RVD by itself looks just as good as old stem cell transplant data. So the treatments are getting better and better and better. So then it becomes harder and harder to tell you what the optimal sequence is.
So we are over our hour. This has all been very, very interesting. Thank you so much for all that that you do for multiple myeloma patients, doctor. And I see one thing in the chat that says, how can I get a recording of this session? The session is, I am recording it. I will post it on our website. It's curemultiplemyeloma.org. And I will send you all a link to that as well once we're done, so that you can go back over this if you want. And I've recorded all the other sessions that we've had as well, so you can go back to those anytime and review them. So again, thank you so much, Dr. Margolis. Thanks everyone for getting up early. We had a big crowd here today, so I appreciate that. And we will be back. Oh, and I also wanted to tell everyone, Sid, I don't know, you can tell them if you want, but we are looking at other options for wine and dine in the D right now, and kind of carefully picking through this. Not exactly sure what we're going to end up with, but we are looking at options to have some sort of in-person event as well as a virtual option too. Sid, do you want to say anything more about that?
I'm just curious how everybody feels about that. Any thoughts or concerns about having an in-person event? Maybe a smaller event, maybe a couple events. We're not sure yet, but we're trying to evaluate everything. We'd love your feedback.
Yeah, and you can just send me an email too with thoughts on that. We're looking at things like possibly making it smaller, finding an outdoor a venue that has an indoor-outdoor option, so that we can maybe be in tents or be outside in October under some heat lights too, some heaters. Anything, those are kind of our thoughts. So please let us know what you're thinking as far as that goes. It's, October, we don't know what's going to be happening now, but we have to start planning. So just give us some feedback too, please.
Mickey, the Ann Arbor group, as you can imagine, has a wide range of responses, but most say they're not going to do much in-person stuff until after January. But there are a few people that are a little more brave and say that they'll be out there if there's an opportunity.
That's good to know.
Yep. That's kind of what we're thinking too, is that there are a lot of people that are, well, just like what Dr. Margolis was talking about today, it's kind of weighing the risks. So anyway, just give me your feedback too on this kind of thing, because we want this certainly for multiple myeloma patients, but it's also for for our other guests that enjoy having this night out too. So anyway, with that, I think we should probably end this today, and we will talk to you soon. Thank you so much, everyone. And we will, we'll be back with you with more information.